Hello everyone, this is Chadi Alraies from SIF 2023. I'm really privileged today to be with Dr. Bailey. He gave a phenomenal talk about the challenges of recruiting for shock trials. Welcome, Dr. Bailey.
Well, thank you. I appreciate the opportunity. And it's great to talk about upcoming trials for shock and the problems that we have in developing those trials.
Right, so it's a challenging patient, challenging cases come to the lab. This is things that happen 2 p.m. but can happen also 3 a.m. So recruitment can be challenging, but also patients are sick, so the decision making is quick.
Yeah, I think that one of the problems in developing trials and recruiting for trials is what you explain. First of all, it's a small percentage of what we do, and what we do is often what we've learned to do, or how we've learned to do it in terms of success, because we haven't had really much objective data to inform us.
Yes.
The other part of the problem is that we don't know how to identify the patients as most likely to benefit. It's the reason we need the trials. But we do know that there are patients who present with shock at a relatively low level that may progress, but they may not, and that there are different phenotypes.
Absolutely. And so one of the challenges is that you just mentioned earlier in the slides is a very heterogeneous population. They're coming with different stages as classified by the SCAI kind of classification for shock. So we don't know when this patient going to fit in that algorithm.
I think one of the good things is that the SCAI classification has given us the opportunity to have that communication. So now we can better identify at least the physiologic state.
Yes.
I think the phenotype of whether these are individuals that may have cardiometabolic shock, they may have cardiorenal, is part of what we're going to have to better understand as we're making our enrollment.
You showed us nice illustration also of how majority of the trials that shock has been discontinued or stopped early due to slow recruitment. Do you think the Protect 4 going to have the same issue?
Well, I think it's challenging as you talk to individuals for many of the same reasons. On the other hand, I think it's beginning at a time where there's a recognition of the importance.
Yes.
I think that there now are more centers that are comfortable with identifying patients. I think that, although I didn't address it, enrollment of patients is going to be an important shift, because we're going to have to develop and follow the process of trauma in being able to have patients consented in the emergent situation. And I think that will be a significant benefit to recruitment as well.
Absolutely. The last part is follow-up. 30 days, 1 year, we don't know which one is the ideal, especially for these critically ill patients.
So I believe that our 30-day follow-up metric we're using today is not adequate. I think it's not a question, we shouldn't approach this with simply did they make it out of the hospital or were they alive. This is not a body count issue.
Yes.
This really needs to be, is what we're doing truly helping patients. We know from our critical care pulmonary colleagues that those individuals, not with cardiogenic shock, but other forms of shock, have systemic inflammation, have a host of problems that are underappreciated. I think we would see that here as well. And so I would advocate that we really need to look more carefully and over a longer period of time. And perhaps what we'll also begin to see is the benefit that we didn't see at 30 days.
Exactly. Well, Dr. Bailey, thank you so much for your time. This is a nice illustration about the challenges of recruiting patients for cardiogenic shock. Watch these videos and others on SIF YouTube channel. I'm Chadi Alraies from South Scale. Dr. Bailey, thank you so much.
Thank you so much. I appreciate it.